Hey, good afternoon, everybody. This is Cara. This is BFR Tuesday, and I appreciate you joining me today. So today, what's on the agenda is I updated the algorithm that I use to decipher which protocol I'm going to use with my athletes or my patients. And so I'm going to go over that with you, and I've included it. I'm going to share it now, so if you want to download it, and then we can take a look. I'll give you a minute to do that, and then I'm just going to open this up. If anybody has any questions prior to me getting started, this would be a good time so I can know when to answer. So I'll give you a minute. And if not, then I'll dive into the algorithm. All right, I'm going to share my screen. All right, so here's the algorithm. I really like this thing, not because it's mine, because it's actually Dr. Loenneke's out of the University of Mississippi. And where we start with this is right here. Does the individual have any contraindications for BFR? And if you're unsure of the contraindications, I break them down into 5 categories. So the first one is that are they at any increased risk of thrombus? Do they have any cardiovascular risk? Is there any risk for muscle damage? Are they at any risk by using a tourniquet? And what tourniquet? And then also, are they pregnant? Are they less than 15 years of age? Or have they had a recent incision, like a surgical incision that's greater than 1 inch? Those are your categories. I've done numerous contraindications and risk factor webinars. So you can either look back at some of my previous ones, or you can ping me and I'd be happy to share. So then we start up here. Does the individual have any contraindications? If the answer is yes, I would consult the patient's physician or surgeon before implementing, and they may or may not approve it. They may approve it, so BFR is approved, or they don't have any contraindications. Now I'm going to ask myself, is the individual mobile? And when I say mobile, is the joint that we're going to work mobile, or as a whole body are they mobile? And when I talk about mobility, I'm looking at about 90% of normal. So looking at an elbow problem, if they don't have 90% range of motion, I'm probably not going to spend my time doing a lot of work with BFR. I'm probably going to spend most of my time doing mobility work. I only have so much time with each patient. If they are not mobile, meaning they have a restriction in range of motion, or they have a cast or a brace, or they're bedridden, I'm going to apply cellular swelling protocol sequence. Cellular swelling I've talked about numerous times in previous webinars, so feel free to look back at those. But limb occlusion pressures are listed here. Time is 5 minutes inflated, 3 minutes free flow, meaning that the cuff is on, but there is no pressure. And then the first one we do is a 5x5 passive, meaning the patient doesn't do anything. I might do that on a first visit just to get somebody used to this. Second visit, we might do 5x5 passive with E-stim. Hold on 1 second. Hi. All right, sorry about that. So then my second visit, I might do a 5x5 passive with E-stim. Here are the settings for your neuromuscular electrical stimulation. 20 hertz, 400 MA, 3-to-1 work to rest ratio. My next visit, I might just do isometrics, 10 seconds on, 2 seconds off. And then my next visit, I might do 5x5 isometric with E-stim. So as a little combination. So like, for example, if somebody's got they're getting ready for a knee surgery, I don't have range of motion of the knee. I might do a quad set for 10 seconds with E-stim and hopefully driving some protein synthesis and growth hormone in order to help and prepare them for surgery. If the individual is mobile, can the individual tolerate loads of 20 to 40% 1 rep max? If the answer is no, then I'm going to do walking protocol. I normally will do 30% heart rate reserve for 15 to 20 minutes. There's no reason why you can't combine different protocols. So let's say they came in and for 15 or 20 minutes, I wanted them to do a walking protocol. And then afterwards I did upper body rehab. That would be a totally legitimate thing to do. If they can tolerate 20 to 40% 1 rep max, then I'm going to start to go into some low intensity resistance training with BFR. Here's your limb occlusion pressures, 40 to 50 in the upper, 60 to 80 in the lower. Rep scheme, 30 reps, 30-second rest, 15 reps, 30-second rest, 15 reps, 30-second rest, 15 reps, 30-second rest. I say don't forget on-ramp, meaning that if I'm jumping right to this, get them used to the cuffs by maybe doing only 1 exercise or 2 exercises at a time. Here's your exercise selection progressions, isometrics. Work from 1 to 2 minutes with a 30-second rest in between, do 2 or 3 rounds. Isolated exercises like a single joint, could be open chain first and then closed chain, 20% 1 rep max. Compound or multi-joint, 20% 1 rep max. And then I'm going to mix compound and isolated exercises, and usually 3 to 5 session exercises per session. If you're going to do eccentrics, use ischemic preconditioning, then heavy 20 to 40 reps. If they can do 20 to 40% of their 1 rep max, we should ask ourselves, can they tolerate higher load resistance training? If the answer is yes, then they should do their higher load intensity or high intensity training, meaning 65 to 90% 1 rep max, but use BFR as an adjunct or as a supplemental form of exercise. So that way they're still getting those high intensity lifts in, which they're going to have better results with. Okay, so there's the algorithm. I'm going to give you a second to digest that, and then I'll answer any questions around it. All right, any questions regarding the algorithm? Okay, if any questions pop up, please feel free to reach out to me. Oh, Maddie has a question. What you got? How do we use BFR and HIIT on the same day? That's a good question. So what I would do is do either HIIT training. Well, you have 2 options. If you're going to use BFR supplementally for your high intensity training, then what I would do is your high intensity training first, and then do BFR, maybe 1 or 2 exercises for any weak links. For example, like my handstand push-ups are pretty bad. So what I'll do is my normal CrossFit training, and then after, twice a week, I'll do some sort of strict press with the cuffs on at 20 to 30% 1 rep max in order to improve strength of my press. That's one way that you can do it. The other way that you could do it, and I also have numerous weightlifting athletes that do this. They do their normal Olympic lifting training, and then twice a week they do supplemental work. And usually it's trying to hit on those weaker links that they have. The other way that you can do it is you can do ischemic preconditioning prior to HIIT to reduce the damage that occurs from the HIIT training. So if I'm in season and I'm trying to still hit people still trying to give them a dose of good exercise during their season without causing a bunch of muscle damage or delaying their ability to go back to practice or a competition. I can do ischemic preconditioning prior to their high intensity training, and that will reduce the amount of damage due to that exercise bout. And if you remember, ischemic preconditioning protocol is 5 minutes, 100% LOP with 3-minute rest. I should say 3-minute free flow times 2 to 3 rounds. And then that creates about a 45-minute window of opportunity. And if you want to hit the same muscle group, it's fine as the hit. But if they've already gotten exhausted, then you might just do some isolated exercises for that, for the area that you're wanting to work more. You just have to use your best judgment. I mean, if they're already fully fatigued from the high intensity training, there's no reason to go in and do BFR. If they're not, then maybe, sometimes, in the CrossFit box, I might do like a heavy lower body day, but I want to hit the upper body. And so there's no reason why I couldn't alternate lower body to upper body. There's no reason why you couldn't add on to your normal workout. The thing with BFR is that it takes all the motor units to full failure. So I wouldn't recommend doing that prior to your high intensity exercise. I would recommend to do it to just like knock out anything that is still existent from your regular exercise. So good question. And that will be part of my level 2 course that I'm writing right now, which is a performance course. Any other questions? All right. Well, thank y'all. I will be back next week. If anything comes up, let me know. For you Americans out there, happy 4th of July this week. And I appreciate you joining me. If anything comes up, ed@edlecara. I'll put that in here, ed@edlecara.com. Thank you.